Well, thank you so much for having me here today, and I'm very excited to present on overlap myositis. Just as an introduction of myself, I'm an associate professor of medicine at the Johns Hopkins Division of Rheumatology. I'm also the co-director of the Johns Hopkins Myositis Center and also the co-director of the Johns Hopkins Autoimmunity Center of Excellence. So I'm very excited to talk about overlap myositis today because I feel like I was reflecting that I've been working on this space for some time now. So I will be giving you a journey into what I think overlap myositis is, and we'll have a little bit of a tour through the different types of overlap myositis. So these are my disclosures. And so the objectives of today's talk is to review the most common types of overlap myositis. And hopefully I can convince you that really overlap myositis does exist. And I think it's garnering a lot more attention now in the myositis community as well. And in fact, I have to say there's recent phase 3 clinical trial, even recruiting patients with overlap myositis. So this is very new for us. And I think we're embarking into understanding all types of myositis and not just dermatomyositis or necrotizing myositis. But you'll hear my talk that, um, there are shades of gray, certainly, which makes it challenging to treat these patients, but also very rewarding. So another point that I'll be discussing today are some key clinical features of overlap myositis, and lastly, management of overlap myositis. So what is really overlap myositis? And you have to go back and dig into the literature. And I remember doing this many years ago. And really, it's not very well defined, unfortunately. But overlap myositis is thought to be, okay, for sure you need to have myositis and have evidence of muscle involvement as defined by having proximal weakness and abnormal EMG or abnormal muscle MRI or abnormal muscle biopsy, and have another connective tissue disease. And usually that's kind of the most strict definition. Of course, there are many different types of connective tissue diseases you can have. And when you look at the literature, actually, and I did this actually probably now 10 years ago, I remember embarking into this space of overlap connective tissue diseases, especially with myositis. And you can see with systemic sclerosis is actually the most common type of connective tissue disease that's associated with myositis, up to 48%, which is pretty high. The other connective tissue diseases that are commonly associated are lupus, RA, and of course, don't forget about other neuromuscular diseases. And you're going to be asking, what are you talking about? So I'll talk about that very briefly in the next couple of slides. So here is a nice diagram where there are intersections of the different types of connective tissue diseases. And you can see myositis is in the middle. And then, as I said, scleroderma or systemic sclerosis is the most common. And then here you have RA and lupus. And of course, I'm sure I could add other circles, but it's just poorly defined in those areas. This other neuromuscular disease, please don't forget about this group. Up to 10 to 15% in some literature will say that you can actually have concomitant myositis and myasthenia gravis. So for us in the myositis center where I work, I actually work at both the myositis center and the scleroderma center, but in the scleroderma center at Hopkins, I truly focus on patients with scleroderma who have muscle disease. Those are kind of my patients that I see in my scleroderma clinic. But don't forget about the neuromuscular diseases because you can have a very challenging situation where someone may have dermatomyositis and myasthenia gravis, and you can't give them high dose steroids because then you can actually precipitate a myasthenic crisis. So it is very important that if someone has symptoms, predominantly more bulbar symptoms with dysphagia, dysphonia, or fatigable weakness, double vision, all these symptoms of myasthenia gravis. Then, and you can also have dermatomyositis, and we've actually wrote a series of these cases in the past. It's important to think about that in a patient who may have significant more bulbar symptoms, even in patients with myositis. Now, you could be like, okay, well, can you have all of these things? Of course you can. You can have like a mixed connective tissue picture. We can have a little bit of features of all of these, including myasthenia gravis. And I have just this type of patient right now who's been really challenging to treat, but she has the definitive high acetylcholine receptor antibodies for myasthenia gravis and lupus and myositis and scleroderma. So I think these can be very challenging to treat. And this is why I think it's actually fun in terms of understanding the disease and exciting to embark into the research space as well. But anyway, this is basically the landscape here of overlap myositis. So I'm going to first talk about RA and lupus in terms of the overlap myositis, but there's not a lot of data, so I'm going to show you here. So these are a really old case series from Brazil, which I thought it was a very well done study. It was 220 patients. And again, 18% of these patients with myositis had overlap. And the most common was RA and lupus in this group. And I think we get a lot of these questions from our patients who have two diseases at the same time with over myositis and RA or myositis and lupus. And they're always asking, is this going to happen in the future or is this happening at the same time? Or do I have to worry about this, right? If you have someone who's, for example, RMP positive, maybe. Anyway, so in this group, in this study, they found that most of the patients who developed myositis with RA happened simultaneously. But if you had lupus and myositis together, it tended to happen either before or after, about 44%. In this Brazilian cohort, it seemed like there were no differences in mortality or disease relapse. So that was quite interesting. Now, if we solely put a lens on those patients with myositis and RA, this is actually the oldest and largest series in 1984, which is so old. But I thought it gave a lot of insights into what myositis and RA can look like together. And they even had histopathologic findings, and they described this. So at this point in time, there were 31 patients meeting ACR criteria, and they all had RA. But what was the picture of the RA? So the classic clinical phenotype of the patients who had RA were they had active synovitis, but they had a synovitis ESR dissociation, meaning they had dissociation with a number of joints, but high ESR. And then RA-CPK, meaning if they had high CK, it seemed like they had actually seropositive erosive RA. But I think, as you can see here, this is an old study, but it actually is hinting to some other disease states, which I will go into, that you can probably see with myositis and RA. But I like this study, and I want to highlight is there just a lot of people don't get a lot of muscle biopsies in patients with RA and myositis because they're probably already on methotrexate or rituximab, and you're already treating them anyway. But in this group, they actually had patients who had muscle biopsies, and you can see 40% had muscle necrosis. And this is even before a necrotizing myopathy was described in the myositis literature or myositis space. So you can see that when we think about necrotizing myopathy, yes, it's classically associated with anti-SRP and anti-HMGCR, but these overlap patients can definitively, and for surely, obviously, even in 1984, can have significant necrosis on the muscle biopsy. So in their paper, they describe rheumatoid myositis, quote unquote, as having perivascular inflammation with myofibril necrosis. I mean, would love to go back to this paper and look at these muscle biopsies again, because I really wonder if these patients mostly had a necrotizing myopathy. But now, that is the past in the 80s. What about now? So more recent papers, if I really think about a classic patient where I see a patient with myositis and RA, I think the first differential for me would actually be someone who has anti-synthetase syndrome, because we know that patients with anti-synthetase can have inflammatory symmetric polyarthritis. And these patients sometimes can even be ACPA positive, CCP positive. And so I routinely, if they have inflammatory arthritis, do check for anti-CCP positivity. And it's pretty well known that if you have, based on this cohort of well-defined anti-synthetase syndrome patients from Lorenzo Cavanaugh in Italy, we know that these patients who are ACPA positive tend to have more radiographic damage and things like this. And so they are patients you want to be more aggressive about treating for joint inflammation. So I think currently in the myositis space, I think our heads, if we're thinking about a differential diagnosis of overlap myositis with RA, we're not classically thinking of, a rheumatoid arthritis patient in the RA classic sense, but I think we're probably seeing it more in this anti-synthetase syndrome. All right, so now I'm going to move on to overlap myositis with lupus. Still not that much. And I think the reason is because patients with lupus tend to have so many other organ manifestations that can be driving their disease with the lupus nephritis or CNS lupus. So, but it is something we should really think about. And these patients, a lot of these patients are already on steroids, which make it sometimes harder to diagnose or do a muscle biopsy. So one of the best studies were done by Dr. Sokos in the NIH, published in JAMA 1981. And these were all sequential patients who were admitted to the NIH for inpatient admission over 6.5 years. And I know it's an old study, but I thought it was a very pure and clean study in that they were really looking at consecutive patients. And you can see that these patients, only 8% had muscle involvement. And similarly to the Brazilian study, most of them 72% had simultaneous lupus and muscle involvement at the same time. But this is very interesting. And actually, one of the senior colleagues who's our chair of the neuromuscular division here at Johns Hopkins has said this to me a lot. And I was like, I don't know if I really believe you, because in the classic sense, perifascicular atrophy is commonly thought to be seen in dermatomyositis. But as you can see here in lupus patients, he described back in 1981 that patients with muscle involvement lupus commonly had perifascicular atrophy without any necrosis. But again, of course, we would like to go back to these patients and see if they met, ACR-EULAR criteria for dermatomyositis as well. Did they have a, Gaucher's papules or not? They don't really describe that at all. So fast forward to now the present time. And what do we know about lupus now, lupus muscle disease? So in 2022, my colleague, Dr. Eleni Tiniakou, looked at the Hopkins lupus cohort with Dr. Andrew Mammon and also Dr. Michelle Petrie. And they looked at the entire Hopkins lupus cohort. And you can see that 7.9% had a myopathy. And their definition was, they had some proximal weakness and or elevated CK or other findings suggestive of myopathic process. And in those patients that they looked at, only 16 had available biopsies, but an overwhelming amount, 50%, had a necrotizing myopathy, just like a patient with SRP or HMGCR. So I think this is important, highlighting again that when you get a biopsy back that says a necrotizing myopathy and they're not SRP or HMGCR positive, we want to do a thorough assessment of determining if someone has actually other connective tissue diseases like lupus or even a rheumatoid arthritis or other or scleroderma. And so in these patients who had myopathy, what was the clinical phenotype of these patients? So in the lupus registry, it's very well defined because Dr. Petrie actually captures all of the SLIC criteria. So they were able to go in and say, in those patients had a SLE myopathy, they were more likely to have a malar rash, an odds ratio of 1.67, photosensitivity, arthritis, pleuritis. And also, interestingly, if they were double-stranded DNA positive, they were also more likely to have a lupus myopathy and pleural fibrosis, which I thought was quite interesting. So now that's the most up-to-date data that I have for our Hopkins lupus cohort and what lupus muscle disease can look like. What do we know about overlap myositis or myopathy with systemic sclerosis? And I am going to spend a lot more time in this section because of the fact that not only is one of my research interests, but as I said before, it is the most common overlap connective tissue disease in a patient with myositis. So what do we know about overlap muscle disease or myositis with scleroderma? Not that much if you go back. And I have to say, I started doing this research back in, probably 2011. So it's been quite some time. And I remember looking at back all the data and pooling, back then we were still reading like much more paper articles, right, than all these PDFs we have now. And you can see that the prevalence of muscle weakness, which is a more broader definition, was like 5 to 95%. It's just all over the place. But there was a meta-analysis that came out around 2013 that also suggested that maybe about 25% of patients actually have muscle involvement. And again, just like lupus, scleroderma patients can get lung involvement, renal crisis, all these other problems. But skeletal myopathy can actually cause significant complications as well. And so it's important that we really consider this organ manifestation, just like we think about the lungs or the kidneys in scleroderma patients. And again, in terms of the true prevalence, I will go into some of the detail where we look back at our entire scleroderma registry, but we definitely need to come to some type of agreement and consensus in the scleroderma world, or even in the myositis world, in these overlap patients. Like, how are we really going to say that someone has muscle involvement? Is it going to be just muscle enzymes, EMG, muscle MRI, or muscle biopsies? And we can have a discussion on that separately later. But one of the first studies that I did actually was back in 2015, but it was started in, I think, 2013. And we finally got this paper published. We took a look at the entire scleroderma database at that time. And because of Professor Wigley, who opened our scleroderma center in 1990, we found a wealth of data. I would say our scleroderma registry is one of the most robust registries in our Hopkins Division of Rheumatology. And so it was such a blessing to be able to look at all this data that's been, truly like mined and collected over many, many years. So basically, the purpose of this study was to determine, well, we know that muscle weakness and myopathy is not good to have, but what are the hard outcomes that we can look at to prove to the medical community and to our patients that if someone has myopathy, then they're going to have more severe disability. And what we did was that from 1990 to 2010, we did a nested case control study and looked at patients who had muscle involvement and who didn't, and then also looked at their outcome measure of HAQ-DI, which is the Health Assessment Questionnaire, or a marker of disability index. Now, there's a patient-recorded questionnaire. And what was interesting to us was that for every 1 point of increase in the muscle severity score that we capture in our database, and basically this means 0 means there's no proximal weakness at all. 1 is mild, 2 is moderate, 3 is moderate, and then 4, I'm sorry, severe, and then 4 is you actually require a cane or a assistive device. And as you can see here, for every point of increase, the disability score markedly increases almost like linearly. And you can see 2 to 3 is a marker of very severe disability. And you might say, oh, this is not surprising. But I think, yes, it's not surprising, but it really cements the fact that these patients with muscle disease can have as much disability as someone with severe skin disease if they're not appropriately treated. And I think this is very important so that we can actually institute treatment if we can. So these patients tended to have, what is the clinical features of these patients who had muscle involvement? More diffuse scleroderma, shorter disease duration, more lung involvement, and obviously higher CK values. And then after we published our paper around the same time, there was a Canadian scleroderma cohort. They also have a very robust research registry. And 1,145 patients also around the same time as us reported that these patients also had a higher risk of mortality. And so you can see the survival of these patients much shorter than someone who didn't have muscle involvement. And their definition was a little bit looser. Any elevated CK or physician-reported myositis or myopathy, which I think is fine because sometimes it's hard to capture this. And so this is something I've learned over the years, but in patients with scleroderma, if they're male, then they tend to have more severe disease. And this is something we see in the US. And I would love to learn about how it's what you guys see in Pakistan. But these patients, if they're men, they tend to have more poor survival or early diffuse scleroderma. And if they have myopathy, certainly look like impacted survival as well. So setting the background of understanding that these patients have really poor outcomes, more severe disability, potentially mortality, we then took a deeper dive into a second study where we looked at, okay, if we know these patients have a muscle disease and these patients have poor outcomes, what is going on in their muscle biopsies? What is the driving force or the pathogenesis of the muscle disease in these patients? So going into it, we thought, oh, we're going to find just like all this fibrosis, and, because scleroderma patients have so much fibrosis in their skin. But actually, we found a spectrum of muscle histopathology. So it's very heterogeneous, which I think makes it very challenging. But as with my myositis hat on, we know that these patients, if we know what their muscle histopathology shows, like, for example, if they have a necrotizing myopathy, we know that something is treatable. And we can do something about it. Now, I know there is some hesitancy about biopsying patients with scleroderma, but for us, our experience has been very good. They heal well. Even in diffuse scleroderma patients, getting a deltoid biopsy is not a big problem for us. But I remember hearing from my European colleagues that they really tend not to do muscle biopsies. But anyways, that's a different story. But as you can see here through panel A through F, this is patient with a lot of perivascular inflammation. This is actually necrosis of the myofiber. So we did see some patients with the necrotizing myopathy. This is primary inflammation, where there's an inflammatory cell, just like polymyositis. This is perifascicular atrophy here. So just like a patient with dermatomyositis. And this is that fibrosing myopathy group that I'll talk about in more detail, where you see endomesial and paramesial fibrosis. And then also here, these are neurogenic changes. So we also saw some patients who had purely a neurogenic process that was going on in their muscles as well. But we did find that there was a subgroup that was quite interesting that I'll go into a little bit more detail about the fibrosing group. Okay, and so I'm going to talk about that. So what is a fibrosing myopathy? So basically, this is a normal muscle tissue where you do a biopsy, and the myofibers are healthy, and then the nuclei are on the outside. But you can see in this patient with a fibrosing myopathy, and we were the first to actually describe this in a manuscript form and describe their phenotype. But what this was actually, Dr. Fred Wigley had always talked about this, but he actually never had a chance to actually report this. So it was really wonderful for me to work with him as a mentor and kind of bring it full circle and be like, look, we really do have these patients, because we knew we had them every time we biopsied it, but we never just kind of collected all these patients together. And with my research interest in the muscle disease cross-section with scleroderma, we started to see this a lot more because we're biopsying these patients more. But you can see that this thick band of connective tissue is in between the myofibers. Like here, you don't see any connective tissue, but this is normal. And you can see this endomesial and then perimesial connective fibrosis here. And which is very interesting is just similar, there's really a paucity of inflammatory cells. You're not going to see a lot of inflammatory cells similar to a necrotizing myopathy, where in necrotizing myopathy, we don't see a lot of inflammatory cells either. But in this case, this fibrosing myopathy is where we see predominant fibrosis. So what is the clinical phenotype of these patients? Not surprisingly, these patients tended to have more diffuse scleroderma, more African American, more deceased patients, so 62.5%. They tended to have higher elevated troponin, 83.3%, compared to those who had an inflammatory myopathy, and these were all statistically significant. So bottom line, these patients do poorly if you find these patients who have a fibrosing myopathy. And these patients, as you can see, their survival is much shorter at 5 years compared to 18 years in patients who have an inflammatory myopathy. So when you're comparing this inflammatory group to the fibrosing group. What about autoantibodies? Because we do extensive autoantibody testing in all of our patients. And you can see, not surprisingly, these patients, but there was not one specific autoantibody that was predominant. But these patients were tended to have SCL70 positivity, U3R positivity, and commonly an ANA nucleolar pattern, which was all statistically significant. So how do we treat these patients with a fibrosing myopathy? We still don't know. We are trying to collect all of our cases. We've certainly collected a lot more in the past 5 years. And we're working on a paper right now to give an update on the patients that we have collected in addition to these 8 patients that were initially reported in 2017. But a lot of these patients unfortunately died, and 5 out of the 8. And all of them tended to die of non-ischemic cardiomyopathy. And the patients who were living were treated with MMF or mycophenolate and IVIG early on in their course. And one patient was just doing well on MMF, and these patients are still doing well at this time. But I think it is very important to, number one, understand that this fibrosing myopathy exists. And this fibrosing myopathy, I always get this question a lot. does this happen more late in the disease? But no, these patients had, up, uh, they had maybe scleroderma for 1 or 2 years, and then they got the weakness, and then we do the biopsy. And so the onset of weakness to biopsy was within 3 to 6 months. This is not a patient with end stage diffuse scleroderma, 15 years, and then we're doing a muscle biopsy on them, because that would be a totally different story, actually, because then you can say maybe it's because they've had scleroderma for a long time and they have fibrosis everywhere. But no, this is really patients early in their disease getting a fibrosing myopathy and requiring treatment. So since then, after our initial publication, there have been multiple publications that have actually really supported what we've also seen. Of course, there are going to be nuances and differences in what we've seen, and actually very cool studies by Dr. Corallo and Cutolo out of Italy. And at Hopkins, we actually don't do a lot of electron microscopy, but they were able to look at 35 patients with muscle biopsies and who had scleroderma muscle disease. And you can see that they were able to show actually microangiopathy with endothelial cell swelling here. And then they also were able to show in this basement membrane, that thick connective tissue was also thickened. And then this is exactly what I was showing you on the H&E in the slide before. They could also see it on the electron microscopy, extreme high power. And they see the extent of the endomesial fibrosis here. So I thought it was very interesting that they were actually able to do more additional studies and look at the fibroblasts in the muscle. And they were able to say, I mean, not the actual fibroblasts, but they were able to show that there was higher expression of TGF-beta, which they believe that was secreted by the perimesial myofibroblasts, which was very interesting. And then most recently, fast forward now from 2017, 16 to now, in the past couple years, there was actually another multi-center study, not in Italy, but now in Spain, where they basically almost kind of did a similar study to ours, where they looked at patients who had a fibrosing pattern, where they had a lot of fibrosis in the endomesial and perimesial fibrosis, and compared them to patients who had dermatomyositis, but also had scleroderma. And you can see similarly that these patients had a poor prognosis and high mortality, just like our study, with the fibrosing patients having more poor survival compared to those who had an inflammatory pattern. But one difference would be is that in their patients, they had more mild disease, but less improvement. And maybe that these patients are different in Spain versus the US. And they did have more cardiac involvement, similar to our patient population as well. So with all that data, I hope I didn't bore you too much, but as you can see, we recently published a review on all the kind of studies that we've looked at over the past 10 years, with a highlight on the more recent studies in the past 5 years about these patients who have scleroderma and muscle involvement. And I think we would really break it down into this fibrosing group, but of course the inflammatory group is like dermatomyositis or necrotizing, that neurogenic group. And I think these two are like something that I actually learned from my scleroderma colleagues, is that some patients don't have inflammation in their muscle fibers, or they may be globally weak, but they're not specifically proximally weak that we would see in the inflammatory fibrosing group. But if they have significant GI involvement and weight loss and diarrhea from small intestinal bacterial overgrowth, they can certainly have weakness and some muscle disease that is more nonspecific and disuse as well. So how do we treat this? As I told you, we still don't know how best to treat the fibrosing group. But right now, we have adopted a treatment algorithm in our scleroderma center and also in our myositis center that if someone has scleroderma and muscle involvement, we tend to give MMF and then IVIG. And we don't know if this is right. I mean, my goal would be one day to really do a small clinical trial in these patients. And then if that doesn't work, we move on to rituximab. But the key point is that we want to avoid high-dose steroids, not more than 20 milligrams per day for a short time, and not an extended time, I'm sorry, because of the risk of renal crisis. All right, so hopefully I was able to kind of distill what we've published on and learned in the past 10 years. And in the past year and a half to 2 years, I also took a deeper dive with one of my fellows by looking at our entire registry with the following questions of understanding the clinical impact of myopathy and scleroderma, and also really getting a better understanding of the risk of mortality. And so what has happened since 2015 to now is that now in our scleroderma registry, we have a distinct definition of what we think is myopathy in our scleroderma database. Before, we did not have this. It was all going by hand. But since we have this, we're able to identify these patients a lot easier now. And so we looked between 1990 and 2021, and now we recently actually looked up to 2023. And I'm looking back in the past year as well now. But this paper, this culmination of this study is being under review right now as a manuscript. But our definition of myopathy, again, was that they either had physician-reported history of myositis, because going back to 1990, nobody was actually doing a lot of EMGs or muscle biopsies back then. And then proximal weakness, and with one abnormal testing here, as you can see. And we looked at all the clinical variables for scleroderma. And what you can see here is that these patients, again, is this actually pretty similar representation to the meta-analysis, that about 17% of patients had a skeletal myopathy. And again, the same things come back about where most patients were diffuse, subtype, and African-American, and shorter disease duration at first visit. I do want to say, I think we do have a high number of patients who are African-American in Baltimore, Maryland, and so we probably have a little bit of a bias here. And this is just highlighting what I already told you in a table format. But I do want to highlight again, interestingly enough, when I showed you just the patients who had the muscle biopsies, you know, the SEL70 seemed to be more prevalent. But now when we're taking a bigger group, we had to go look at 672 patients and see if they had a muscle biopsy ever done, which took a bit of time, and I'll show you that data. But you can see that these patients, that 672 had muscle involvement, and that association of SEL70 disappeared. It was, I mean, p-value of 0.06. But centromere here, you can see, seem to be protective in some way. So if you were centromere positive, you didn't get a muscle disease. And again, patients tended to have a higher risk of mortality. And overall, for this table, I would say patients had a greater burden of disease, more cardiopulmonary disease, more GI disease was also seen in these patients with myopathy. And when we looked at these 3,000 patients, we also were able to show that these patients, in regression analyses, in Cox regression, we're able to show that there was an independent risk for death if you had myopathy. And you can see the survival estimates here, much lower, which is very statistically significant in those who had a myopathy. All right, I'm going to change a little bit of corners, but I'm going to connect the dots. So why am I now switching gears and talking about troponin elevation? And I think this is something now really dear to my heart, because I have now learned the hard way about how these patients can actually, because heart is muscle. And I think we forget about that a lot of times because we're so focused on a patient's scleroderma skin and their lung and their obviously kidneys and their Raynaud's and the digital gangrene. But what are they actually dying of is a big question. And this has been always on my mind for the past 15 years. And this study that we looked at gave us initial insights of why this association with the heart and the muscle may be very important. So in this study, what we wanted to know were what we were seeing, and I don't know if you guys see this in Pakistan, but it would be really interesting to know, our patients, sometimes we would check troponin. And we've been checking it for years. And we would see that these patients would have elevated troponin levels. And we didn't really know what to do with it. You know, the lab will be flagged and it would be red saying it was positive. And we would obviously do the echo and everything looks okay. But we were like, they just have a troponin leak and we're not sure why, obviously. But they didn't have high blood pressures. They didn't have atrial fibrillation. They didn't have heart failure. So we always wanted to understand what were the clinical characteristics of those patients who are troponin positive. So we did a study where we looked at patients who are troponin positive versus troponin negative. And you can see the key features I summarized here. They tended to have more diffuse scleroderma history of muscle disease, and of course, if they had elevated troponin, they tended to be dead, and the history of renal crisis. But I want to highlight here, we wanted to then ask the question, if you had an elevated troponin, what were the risk factors that preceded that elevated troponin? And we clearly saw that for the odds ratios were much higher if you had a lower age of onset, of scleroderma onset. If you obviously had a coronary artery disease, which makes sense because maybe you were going to have a heart attack, and that's why the MI, the troponin elevation happened. If you had low ejection fraction because you had a cardiomyopathy, that's why your troponin was elevated. But again, this comes back to the myopathy history. If they had a history of myopathy, they preceding an elevated troponin, before the elevated troponin, they tended to have skeletal myopathy. And if you look at the muscle characteristics of these patients, they were overall weaker, they had higher CK, and if you had troponin elevation, you had muscle edema on MRI. And you can see, obviously, not surprisingly, that those who had elevated troponin tended to have more cardiac events and higher mortality. So why is this important? And now I've actually embarked into another research space, which is already kind of related to the scleroderma muscle and myositis, is that if you go back, there's a high risk of sudden cardiac death. And this paper has been highly cited back in 1993 by Dr. Follansbee and Metzger from University of Pittsburgh. But I think it's been forgotten. And I thought, I read this paper more than 10 times probably now because it's always been on my mind why suddenly my patients would suddenly die in their sleep. Or I would get a call from a family member that, she was doing well, but suddenly she had said she had palpitations, and she unfortunately died in her sleep. So this is unrelated to pulmonary hypertension. This is truly related to the myocardial disease. And he described this highly malignant form of myocardial disease where you get conduction abnormalities, ventricular arrhythmias, and sudden cardiac death. And the highest risk group were the patients who had, muscle involvement, had this highest risk of the sudden cardiac death. And the thought was that there was some myocarditis ongoing. And so now in my mind, doing research, sometimes you feel like two forks in the road are coming together where, I've been studying scleroderma muscle disease, for the past 10 years. And then now I'm understanding the fact that the heart is very important to understand why some of those patients who are so dear to me actually passed away, potentially because maybe there was some myocardial involvement. And so I was quite surprised. We were actually, I don't know if you guys been having this a lot, but you guys in Pakistan, but in our hospital, we were seeing a lot of cases of myocarditis. And we had wondered, is this something viral? But we do all the viral serologies, and these patients are so sick, they're admitted to the hospital. And or was it the COVID vaccine? We're thinking about all these things, but we're seeing all these cases of myocarditis in the hospital. And some of the patients, not all, were patients who had myositis overlap. And interestingly enough, we noticed that these patients were anti-coup positive. And so we reported this, and you can see this is an endomyocardial biopsy of these patients with inflammatory cells. And but the key point in this case series was that these patients had atrial and ventricular tachycardias, just like that 1993 paper. And this subgroup of anti-coup positive patients are patients we really need to be careful about, I think. And I remember when we were writing this case series, I was thinking, oh, we're going to be the first people to report this. This is so important. But actually, out of Italy, it was like a research letter that was just published like maybe 6 months or a year before our publication, where they also reported that anti-coup positive patients tend to have more cardiac involvement. And now I wonder if back in that 1993 paper, maybe those patients were actually cardiac, maybe were coup positive as well. Anyways, so that's the coup story. And this is a image to highlight that, please don't forget about these myositis-associated autoantibodies, because we always think about the MSAs, myositis specific. But clearly, these patients with overlap myositis have these distinct autoantibodies. And when these are positive, we do really, especially with the scleroderma myositis group, I think we have to be worried about some cardiac involvement. And more to come because we're doing a lot of exciting work in this area to understand that intersection now between the heart and the muscle. And we have some papers that are being submitted right now, shortly, hopefully, on looking at myocarditis and myositis as well. So conclusions of my talk, sorry, I had to talk your ear off, but this topic is dear to my heart as well. Hopefully I was able to impart to you that overlap myositis can exist with many CTDs or connective tissue diseases, but I think so far, the most common is scleroderma. And this fibrosing myopathy is a unique histopathologic subgroup. And don't forget about this high-risk association of cardiac and skeletal muscle disease. And really, I really hope that we'll have more future studies to better classify patients with overlap myositis so that they can qualify for trials to better predict outcomes and a better treatment, tailored treatment algorithm and plan for them. So thank you for your attention. And these are my acknowledgements. And if you have any questions, please feel free to ask. Thank you so much.